Okay. Hello, my name is Eve, and I'm Eve from the Bible, and today we'll be talking on my podcast about Addison's disease. Okay, so we first have to understand what it is. This is a disorder into which there's destruction of all the layers of your adrenal glands. Your adrenal glands are responsible for releasing cortisol, aldosterone, and your gonad hormones. One second, I'm sure I'm not gonna say it. And okay, androgens. It's called androgens, so like DHEA and androstenedione, which can then be converted to testosterone and estrogen. Okay, so when I say the sex hormone, estrogen for women and testosterone for men, but however the adrenal glands ain't releasing testosterone in the adrenal gland, it goes to the testes in the men to be transformed into testosterone. It gives the men their deep voice, their masculine appearance, and things like that, and estrogen as well as with the woman. So when you have Addison's disease, for a woman, it's more profound in women. Okay, you'll lose your ability to have your cycles. Okay, you need to amenorrhea without a cycle. Okay, so anywho, sorry to get it all spaced out like that, but yeah. So there's a primary and a secondary route into which you will get Addison's disease. The primary deals specifically with the adrenal gland itself, meaning that there is something targeting the adrenal gland on its own. Okay, and some primary reasons as to why the adrenal gland can be destroyed. We have adrenal cortex injury. So you might have a car accident. You might have autoimmune disease that's targeting your adrenal glands where it's injured. Okay, what else? Adrenal metastasis, like let's say you have a tumor somewhere in your lungs or in your breast or something like that, and it breaks off and travels to the adrenal gland and destroys the adrenal glands. You can have adrenal hemorrhage, and this is when a bacteria is eating your adrenal gland, causing it to bleed. Okay, like that. Caseria is that bacteria there. Is there anything else? Okay. So again, we got autoimmune diseases with adrenal injury, got adrenal cortex injury. We have adrenal infections, like if you got TB or had TB, if you have HIV, this can mess with that. Okay, so again, with primary, there is something that, like targeting the adrenal gland itself. Primary, there's something else. I mean, secondary, there's something else preventing the adrenal glands from functioning the way they should. And let's talk about those real quick. Because when we talk about these, we're going to get on to why cortisol, aldosterone, and your sex hormones that the adrenal gland releases, what happens if they're not being released, if they're being destroyed, okay? But we have to understand that there are methods or ways into which your adrenal glands can get destroyed, okay? So the primary, again, is where it is on the adrenal gland itself that's preventing the release of your hormones that come from the adrenal glands. And again, those are adrenal cortex injury that's directly happening to the adrenal gland, okay? Adrenal injury, there's something, your autoimmune, those antibodies are targeting your adrenal gland cells, okay? Adrenal infections like TB, HIV, okay? And adrenal hemorrhage, where the bacteria is destroying your adrenal gland. And then we have adrenal metastasis, okay? Where the tumors break off and travel to that area and destroy. For the metastasis, it has to be both adrenal glands have to be 90% affected for this to be considered a tumor for that, okay? All right, so now let's talk about the secondary causes of adrenal insufficiency. But just know Addison's disease is the primary, okay? Okay, now, hold on. Secondary adrenal insufficiency problem is that it's something with the hypothalamus or the pituitary gland, okay? The pathway into which cortisol or aldosterone and things like that, it starts in the hypothalamus. CRH, well, we're going to talk about cortisol. But one second, because I did. Okay. Okay. So I just did one quick recap there, okay? I'm not doing this only for y'all, okay? I'm doing it for me so that it can get stuck in my brain better, okay? So let's talk about cortisol, because that's the main reason behind this disease is that you're not producing cortisol. Cortisol is a stress hormone, okay? Let's say if you got chased by a dog, but if you don't have cortisol, you're not going to be able to run from that dog or be able to react to it. Your body's going to it's going to glitch out. Imagine that. When you get mad or when you're in an argument, you don't think about that there's a hormone that's allowing for you to get like that. And what happens if it's not being secreted? You can literally die. It's like this. We're going to get back talking about secondary adrenal insufficiency. It's like this, it's a stingray in the ocean that if you tickle that stingray, I don't know if it's a stingray, it's one of the flat fishes. But they say if you tickle it, it will die. It will laugh, but its nervous system can't tolerate that, you know what I'm saying, that ticklish feeling. So it dies. And that's what happens to us as humans if you have Addison's disease. You don't have another scenario. Let's say you in an abusive relationship or something like that, and your dude come at you and start throwing blows on you, okay? Well, if you got Addison's disease, and you gonna get mad, you want to get mad, you want to react, but if you don't have cortisol being released from your adrenal glands to help you be able to deal with that stress, you can literally die without dude even touching you. Yes, I've been in a 7-year abusive relationship, but in 2 or 3, it was 2 battered women shelters. So when I say I have full right, even if I went through it, going through that, to use that as an example. Do you know what I'm saying? All right, so let's talk about the secondary adrenal insufficiencies. What can cause it? So again, the pathway into which cortisol is made is that the hypothalamus secretes CRH, which is the corticotropic releasing hormone. It goes down to the pituitary gland, the anterior pituitary gland, and it stimulates the release of ACTH. ACTH goes to the bloodstream and travels to the adrenal glands and gets turned into cortisol. in the adrenal glands. That's pathway. But what if you have a tumor? And that's a tumor. That's not a tumor. Hypopituitarism. What if you have your pituitary gland infarct? There's not any blood supply going to it. What can cause it? Well, if you have sugar diabetes, where it's cutting off those small capillaries that can prevent blood flow to the pituitary gland. Okay. A polyp is a massive tumor that is on the pituitary gland, and the size of this thing can compress or squeeze vessels to where they get shut off to where the pituitary gland itself is not able to get perfused with blood, and so it dies. And if you don't have the pituitary gland releasing SDH, okay, how are you gonna get your cortisol made? There's a disease called Sheehan's, and this is in postpartum, or after you have a baby, you're leaking blood from your uterus, you're bleeding a lot, and that decrease in blood pressure can decrease the blood volume, BP, and it'll stop the blood flow to the pituitary gland, the Sheehan's. And this bad, y'all. Infections that can cause, infarctions. We said infarctions that can necrot the pituitary gland itself. Malcoadenoma. This is a mass of pituitary tumor, okay, that's stopping the blood flow to the pituitary gland. So let's talk about, so again, hold on. I know I'm everywhere, but I'm really where I need to be. You need your adrenal glands to release cortisol so that in those moments where you need to fight or you need to, get in your fight or flight mode, without cortisol, it ain't happening. Your body about to die because of it. And it takes a lot of glucose for you to be able to holler at somebody, fight somebody. Y'all, it takes a lot. Just imagine once first you chill, now someone call you out your name or something like that. Oh, don't fight where I'm up. You know what I'm saying? You went from calm to energetic, ready to chunk on blows. You know what I'm saying? That take energy for you to do that. I'm talking about a lot of sugar. Your body literally taking, cortisol is taking the sugar from your bones, your muscles, and your adipose tissue to generate that sugar that you need to get energized like that. Now, what happens if you ain't got cortisol to do this? You literally about to die from it. Another thing that can cause your adrenal glands to not function right is that if you've been taking corticosteroids, which is perceived as cortisol in the body, if you've been taking it for a long time, and then when that happens, your adrenal gland is telling the brain, okay, well, I got enough cortisol, so you ain't got to make no more. Because you putting cortisol in another route. The adrenal glands don't have to make it. That's how they're going to perceive it. And so with them shutting off that negative feedback, telling the hypothalamus to stop producing CRH, okay, this is going to cause your adrenal gland itself to shrivel up to a trophy, to shrink. And when it does that, it's not going to produce cortisol. So what happens if you stop taking your cortisol medicine, okay? You can die from this. So you abruptly stop. Like I said, if you've been taking corticosteroids, like let's say these wrestlers been using steroids to help them fight in the ring and stuff like that. And then they've been doing it for years, but they just automatically stopped taking it. Their adrenal gland has already shut down because it was like, well, I ain't got to produce cortisol. They've been putting it in with pills, or I ain't got to do it. And you stop taking them pills, that adrenal gland already stopped working. And so that's why these wrestlers they be dying, because they don't understand how they work. It's very important that when you start, if you being diagnosed with Addison's disease, that you never miss a dose of your steroid medications. This is vital, bro. Mothers, like, if you like me, holler a lot with your kids, you know what I'm saying? That takes sugar energy to do that. It's high levels of cortisol, your stress hormone being released for you to be able to do that. And what happens if you don't have it no more? In the midst of you hollering at your kid, you can literally die. When I say it's a blessing to have God on your side, because he the ultimate doctor. He going through the okay, he check your body out, you know what I'm saying? Like, okay, you need to quit hollering. And y'all, he made this game for himself. Look how many humans it is on the planet. God is able to check every last one of y'all body out and know what's wrong with you. Y'all, he was bored for so long. He made a beautiful game for himself. You got to eat them, you got to feed them, you got to clothe them, you got to keep them safe from other animals, other humans that you made. Like, that's a hard game to play, bro. It's hard to chess. Chess ain't well. He playing chess. Every human is a chessboard game, and he playing chess to a degree with each human. Like that. How do you do something like that? That's beautiful. But let's talk about the effects of cortisol. What does it do for the brain? You have a decreased stress response and a decrease in your central nervous system activity. This leads to fatigue and lethargy. You're gonna be real tired. Because just imagine if you got cortisol, you hot. Yeah, I'm like, you know what I'm saying? And then you take that cortisol away, and you just like, somebody come over there and pull you like, what's up, big head? And you just like, usually who call it big head? No, you know what I'm saying? Usually you would be like that, but you don't got cortisol. You go. This ain't funny. I'm trying to help y'all understand better. Because your brain, your nervous system has a big role to play in you getting it hyped up like that. And if it's not working, what you mean you're not gonna be? You're gonna be tired. Okay, let's talk about the liver, your metabolic dysfunction, because your metabolism is how fast your cells of your body is able to turn the food that you ate, or glucose, because the food that you eat gets turned into sugar. How fast your body is able to turn the sugar into energy for it to be able to for you to move. But every movement that you make, your cell is working like crazy for you to be able to move in peace. Don't you moving like it's just ain't nothing. It's a carefree thing. Okay, your cell is going through work, like the hard work you go through in the factory. You work in the factory. That's what your cells do every day, and they need energy to do that. Just imagine your cell, little small humans in your body. You got the skin department, your muscle department, your nerve department, okay? And they all, like they say, like they run a railroad, for you to move comfortably. 1 second. We'll edit that out. I'm gonna have to use this because I'm tired of this thing moving on me. It works. So your cortisol, it helps to initiate gluconeogenesis, where the body takes non-carbohydrate sources to create glucose. And what I mean by non-carbohydrate sources is usually you get your sugar from the food that you eat, which are carbohydrates, okay? But cortisol, it goes a different route into getting that sugar without that. Like your bones. Amino acids are the building blocks of protein, okay? Your bones are protein. Your muscles are proteins, okay? Made up of amino acids. Well, cortisol is going to break them up and create glucose out of it. Because you understand something. The amount of sugar that it takes for your body to be in that fight or flight state, let's say there's somebody come up there and hit you out of nowhere, and you get mad. You hit, you know what I'm saying? You get real mad. It takes a lot of sugar to get you like that. Just because it's so easy for you to jump into that mode, don't mean that your body ain't requiring a lot of energy for you to get there. It's real fast. It's good. You know what I'm saying? Woo. So cortisol, like I said, we said glyconeogenesis, creating sugar from non-carbohydrate elements. Okay, and then we have glycogenolysis. Glycogenolysis. Breaks down the storage molecule glycogen into glucose, which provides energy to the body. So you have glycogen stores that your liver makes and your muscle cell makes in case you ain't got no energy or sugar in the bloodstream. You'll use that pantry stored sugar to keep you energized. But what happens if you use all that up? When you mad, that's why when you get through you're fighting people, you get through fighting people, you be real tired and stuff like that, because your body uses a lot of energy, a lot of sugar for you to be able to chunk and blow when you fall. You know what I'm saying? It takes sugar. And if you ain't got cortisol and Addison disease to get you like that in the middle, you fight. You run the cortisol that way. You can literally drop dead in a minute. You can be willing to fight everything, but you ain't got cortisol to help you stay like that. You can literally drop dead in the middle of your fight. But there's no game out here. There's no game out here. So again, cortisol helps with glycogenolysis, using your stored sugar for energy, and gluconeogenesis, turning non-carbohydrate elements into sugar, like your bones, your muscles, and your fat. You can literally suffer from hypoglycemia with Addison's disease. If you ain't got cortisol to help get that sugar in your bloodstream, to unlock glycogenolysis, to use your stored sugar, you always need to have sugar in your bloodstream, okay? And what happens if you ain't got cortisol that's going to help make it or get it in there? You ain't going to drop dead, right? Even your blood vessels themselves need the sugar that you eat from your food for them to be able to constrict and pump. We have to stretch and dilate and contract with the blood flow, to push the blood there. That take energy to do it. If you ain't got no sugar in your bloodstream, your sugar is like literally 10. You know what I'm saying? It takes energy for yourself, for cortisol to be able to turn, to initiate gluconeogenesis or glycogenolysis. It takes energy, that process to turn that sugar into ATP or taking the stored sugar and breaking it down to glucose. That takes energy to do that. If you got 10 look, your sugar level is 10. How your body gonna do that? You're gonna drop dead, man. So let's talk about the effects of cortisol, not having cortisol on the heart, okay? Because we all learned, well, you should learn, that cortisol helps help your heart beat faster. Okay, so you have cardiovascular dysfunctions. You know, your heart needs sugar to pump too. Okay, it's connected to the blood vessels to pump the blood. The blood vessels of the heart that feed itself has to have glucose for it to be able to have energy to pump. And if you ain't got cortisol, what you think will happen to your heart? You have cardiovascular dysfunctions. You have decreased receptor sensitivity to to norepinephrine, epinephrine. Okay, cortisol likes to speed up the heart rate. Okay, and if you don't have this cortisol doing this, you have massive vasodilation. Your vessels are going to dilate because cortisol helps constrict vessels to increase your blood pressure. And if you ain't got cortisol, the how far your vessels can dilate is what's going to happen here without cortisol. So what do you think it's going to do? Your blood pressure is going to plummet to the ground. You're not squeezing that blood through the vessels. It's like throwing a hot dog down the hallway. It ain't nothing holding on to that blood or that fluid in your vessels, because the vessels themselves are dilated. If you had cortisol, it would have constricted it. But you ain't got this here. So just imagine if you're in the middle of a fight and your cortisol just cut off. Your vessels going, and you're going to plummet because your normal blood pressure is 120 over 80. Okay, if you ain't got cortisol to maintain that good blood pressure, your blood pressure 50 over 10 or something like that. It's going to plummet, y'all. And if you ain't got blood pressure, how cells going to get perfused with oxygen, with nutrients? Okay? When God said your body is a temple, it really is. It took a lot for him to be able to make a chain reaction, for us to be able to walk and talk on our own and feel what we feel on our own. We literally need to be in a chair, a royal chair, just sitting there to a degree. And just be thankful that you existed. Y'all playing with these bodies. Playing with. This vasodilation is going to lead to bradycardia. The heart has vessels that supply blood to itself. So when the heart pump is pumping that blood to itself too. If you have massive vasodilation to where the blood can't even get to feed the heart itself, do you see how you'll have cardiovascular problems? Decreased cardiac output. You'll have orthostatic blood pressure. Okay, that's when you stand up and you get dizzy and you sit back down. Your vessels are dilated, bro. Like how you gonna try to stand up fast like that, man? Well, you about to plummet over. Blonde and bridges falling down. You can't just get up fast like that. We have decrease aldosterone. What is aldosterone used for? It helps to increase the blood pressure. And what aldosterone does, it holds on to your sodium electrolytes, and that sodium is going to draw water with it, and it's going to have you pee out potassium. But without cortisol, excuse me, not cortisol, but without your adrenal glands being able to produce aldosterone to increase your blood pressure, what do you think is going to happen? You're going to be peeing out your salt, peeing out your water, and retaining your potassium. This lead to hyperkalemia. This have effects on your heart, bad effects, that is. Okay, if you don't have aldosterone to help retain fluid to increase your blood pressure, what do you think is going to happen to your blood pressure? It's going to plummet. Now, we talked about the effects that cortisol has on the brain. You're not going to be able to be aware of your fight or flight state, okay? You're going to be tired. We talked about the effects on the liver. You're not going to be able to produce, create sugar from non-carbohydrate elements to be able to help you in your stress moments. These are hypoglycemia, hypoglycemia. We talked about the effects of cortisol not having cortisol on the heart. Now, we're going to talk about the effects of not having cortisol on the kidneys, because we really just said it, okay? Aldosterone helps the body to retain fluids by allowing sodium to attract water to it. It's going to keep your sodium. It's going to attract the water to put in the vessel so that your blood pressure increases. If this is not happening, you're going to have hyponatremia. There's low sodium levels in the blood. Hyperkalemia, high potassium levels in the blood, and you're going to be acidic. You're going to be peeing out. Excuse me. The concentration of your blood is going to be high. This is acidosis, because you're peeing out your water and your salt, and then what's left in there are your element, the plasma proteins. It's high. Okay, with the integumentary, with the skin, because with people with Addison's disease, they have like a bronze color. Now, it was a president. I think it was. They said it wasn't Bush. It was a president that had Addison. Let's look at it right now. John F. Kennedy. Yeah, because they said he had a tannish color to him. And this happens because when, there's a lot of ACTH being made, somehow the body breaks it down into two different segments, and that other segment called alpha melanocytes, I know, this protein that got broken down from ACTH, okay, it travels to your melanocytes in your skin, and it causes a browning of your skin, darkening of skin, hyperpigmentation. And this is a key sign, we're calling it, that you have Addison's when your skin color gets darkened. You might have those black spots on your lip, on your hand. Let's talk more about, go back to the brain here. You have encephalopathy, delirium, difficult to arouse you. If there's be some agitation, this is real bad. So it's we're really finished here. What they do. Addison's disease is treated with daily, lifelong, or corticosteroid medications, such as hydrocortisone to replace the missing stress hormone cortisol, and sometimes fludrocortisone to replace aldosterone. During times of physical or emotional stress, illness, or surgery, patients require a higher stress dose of corticosteroids, which can be administered intravenously if oral intake is not possible. Individuals with Addison's disease should wear a medical alert bracelet, carry a steroid emergency kit, and have regular follow-up appointments with their healthcare provider. Y'all, this is really serious, y'all. So it's good to have, they say stress is a silent killer. It really is in here, in Addison's disease. Like, once you want to go off on somebody, y'all take that for granted, bro. Y'all take advantage of being able to go off on people, because it's literally, there are people in this world that can literally die from going off on somebody, like, because they ain't got the stress hormone to do it. Y'all be calling people P, you know what I'm saying? What the, you say, mother? Y'all be taking that for granted, bro. People with Addison, as soon as they P, I'm not laughing at nobody, but I'm saying, there's a test that they can do to see if you have either primary or secondary. There's a blood test that measures cortisol, ACTH, and electrolytes, followed by an ACTH stimulation test to confirm insufficient cortisol production on the adrenal glands. A doctor will also look for signs of autoimmune disease and perform imaging tests like CT or MRI to check adrenal gland health and pituitary gland issues. An ACTH stimulation test to check the adrenal glands response, and sometimes imaging tests. So what they'll do, they'll give you ACTH, and if your adrenal glands turn that into cortisol, okay, I'm gonna watch that because I had cut off to make sure I was, let's go to it real quick because I just edit this out. Adrenal insufficiency is the overall term for Addison's disease.
Nervous system hypothalamus is in the vicinity, right? So it may even trigger a fever process. It's not really infectious related, but it could be due to kind of hypothalamic alteration. So it's like really difficult to arouse them. Are they in like a comatose state? You know, are they agitated in some form? Is it really hard to arouse them? These are really some things that really help you to think about this, especially in a patient who is profoundly hypotensive, hypoglycemic, hyponatremic, hyperkalemic, hypoglycemia. I would really think about that. Plus, it also may stimulate a fever production. This may be due to kind of like a regulation of the hypothalamus, because it's, again, it's affecting the central nervous system. The hypothalamus is in that vicinity, right? So it may even trigger a fever process. It's not really infectious related, but it could be due to kind of hypothalamic alteration.
So you will have a little bit of a fever here.
So a patient who has an adrenal crisis is an acute form of adrenal insufficiency.
That's what I was talking about. Adrenal crisis! Oh my goodness, how was I about to end the lecture without that? Okay, so you remember, and excuse my real chill, I just took my medicine, okay? So remember all the bodily systems that we talked about that cortisol acts on if you don't have it. Well, with adrenal crisis, it is your cortisol levels are so low that you about to die, bro. See, you know, Addison's disease is like a mild to moderate low cortisol level. But with adrenal crisis, it is that times steroids on crack, okay? You literally about to die. I know, right? You're gonna have a fever, man. You're not gonna be able to make glucose. Your sugar level's gonna be real low. You can go into shock here with that low blood pressure. What can trigger the stress response? Infections, just post-op from surgery, getting mad for no reason, a car accident. You ain't got cortisol to help you deal with that car accident injury. Like, you can literally die. Whew.
And that means that it could be acute. So sometimes if patients have Waterhouse-Friderichsen syndrome, they can actually go right into acute adrenal insufficiency. They don't even have to have chronic adrenal insufficiency. But if somebody has chronic adrenal insufficiency and then you introduce a trigger or a stress response, you can definitely put them into acute adrenal insufficiency or adrenal crisis. You just have to really figure out what are those triggers. Oftentimes, the one that usually picks up on the exam is the sudden discontinuation of steroids.
Y'all, this is real serious, okay? If you're taking steroid medication, and I would hate to be a nurse of a patient who takes it and they refuse their medicine a lot, like that would literally have me putting my quitting letter. If I got a patient that takes steroids and they refuse to take it, that would be my last day working there. It will. Because how dare you put me in a situation like that to where they're not taking their medicine. And they literally need it. I'm not doing it. It's other jobs for RN. And they don't want to.
You just lose the whole exogenous system. Your body has to go into this fight or flight mode to figure out how to make more of it, and it just won't be able to. And so you're going to this extreme adrenal insufficiency. And it's really important to be able to think about these. All right, so we talked about adrenal insufficiency with pathophys, cause. We've gone through the findings. We've gone through the complications. Now we have to dig into the diagnostic approach. All right, my friends. Now we talk about how we approach the diagnostic section of adrenal insufficiency. So I have a patient comes in. Orthostasis, hypoglycemia, hyponatremia, hyperkalemia, metabolic acidosis, fatigue, lethargy, the eosinophilia, a lot of things that point to adrenal insufficiency. So what am I going to do? Well, the first thing is I get cortisol, because cortisol is low and I have adrenal insufficiency. If it's low, okay, cool. There's definitely the possibility. Then I'm going to figure out, is it coming from the adrenal gland or is it coming from the pituitary? Then I get the ACTH. If the ACTH is then low, then what is it?
If it's low, if ACTH is low, this could mean there is a pituitary problem. This could be secondary, right?
Right. It's likely secondary. Okay. I just have to ask myself, is it due to the sudden discontinuation of steroids or is it a pituitary problem?
So secondary. So if they're not taking their steroids, you taking that medicine is acting as if that medicine bottle is a pituitary gland and it's help to supply cortisol. So if you're taking medicine, this is a secondary, okay? Because primary, there's something wrong with the adrenal gland itself. Secondary is something else that's preventing the adrenal glands from functioning, like the pituitary not working to release that hormone, or you're not taking your medicine. That's important to know that too.
So what am I going to do? Well, the next thing I'd like to do is I'd like to make sure, because sometimes it's really important to just completely determine that, oh, it really is secondary adrenal insufficiency. So what patients will sometimes get is they'll get something called ACTH stimulation test. And basically, you give them ACTH and then see how they respond to that. And another thing that you can do in combination with this to really determine that it is secondary and it's not primary is check the aldosterone and the renin levels. The reason why is in patients with primary adrenal insufficiency, their aldosterone levels will be low. The renin will be high.
In primary, aldosterone low, because in order for aldosterone or cortisol to be released, the hypothalamus has to release the releasing hormone for it. Dang.
So I have a hot take. AI is not just a buzzword. If you use Monday CRM.
I'm so glad you said that.
Glucose checks.
Something about this thing.
No, I just watched
going back to late nights like this, but it doesn't have to be this way.
Setting them an adrenal crisis of a kind of a Now, we move to the next section, which is how we treat adrenal. Sometimes you need to do a fine needle aspiration. pH. There's the cause. Adrenal. What I'd like to do is I'd like to make sure, because sometimes it's really important to just completely determine that, oh, it really is secondary adrenal insufficiency. So what patients will sometimes get is they'll get something called ACTH stimulation test. And basically, you give them ACTH and then see how they respond to that. And another thing that you can do in combination with this to really determine that it is secondary, it's not primary, is check the aldosterone and the renin levels. The reason why is in patients with primary adrenal insufficiency, their aldosterone levels will be low, the renin will be high. In secondary adrenal insufficiency, their aldosterone levels will be normal. And so that's the important thing to remember. So the next thing I'd like to do is I'd like to make sure, because sometimes it's really important to just completely determine that, oh, it really is secondary adrenal insufficiency. So what patients will sometimes get is they'll get something called ACTH stimulation test. And basically, you give them ACTH and then see how they respond to that. And another thing that you can do in combination with this to really determine that it is secondary, it's not primary, is check the aldosterone and the renin levels.
Okay, because if it's primary, if it's secondary, you won't be able to release renin or aldosterone. But if it's primary, you won't be able to. Okay, again, they'll do a aldosterone and renin level check to see how they are at normal levels. And if they check it and it's elevated, it's within the right range of things, this is how you know that it's a pituitary problem. Because if it was secondary, if it was primary, meaning the adrenal gland itself is malfunctioning, you won't be able to produce renin or aldosterone. But if it's secondary, your levels will be fine. And it's just a pituitary problem. Okay, let's get here. It's either a pituitary problem or you'll just stop taking your corticosteroid medicines, okay?
Patients with primary adrenal insufficiency, their aldosterone levels will be low. The renal will be high.
In primary, it'll be low because it's something wrong with your adrenal itself.
In secondary adrenal insufficiency, their aldosterone levels will be normal. And so that's the important thing to remember. So if I go ahead and I give them ACTH, and a patient who has a pituitary problem who's already not producing ACTH, I'm replacing it, what's going to happen? They're going
to... If ACTH is given in secondary, what's going to happen? It's just going to be increased, and they're going to have a decrease in cortisol. If I give it in secondary, there's a pituitary problem. If you give ACTH, the adrenal gland is going to increase, it's going to make it into cortisol, so you're going to have increased cortisol. So if ACTH is given in secondary, which is there's something going on with the pituitary gland itself. If you give ACTH, the adrenal gland is going to turn it into cortisol. So this is how they know that it is something dealing with the pituitary, or you abruptly stop taking your medication. So it's going to have an increase in cortisol.
Beef up their cortisol. That's definitely an indicator that the patient has secondary adrenal insufficiency. And if I check is in patients with primary adrenal insufficiency, their aldosterone levels will be low. The renal will be high. And secondary adrenal insufficiency, their aldosterone levels will be normal. And so that's the important thing to remember. So if I go ahead and I give them ACTH, and a patient who has a pituitary problem who's already not producing ACTH, I'm replacing it, what's going to happen? They're going to beef up their cortisol. That's definitely an indicator that the patient has secondary adrenal insufficiency. And if I check aldosterone and renal levels, they're completely normal. That's a secondary AI. It's probably pituitary, or it could be a sudden discontinuation of steroids. How do I determine that? Get a pituitary MRI. If I do that and I say, oh shoot, they got a huge goom block in their head, there's the cause. Or they infarcted their pituitary, there's the cause. And if I don't see that, or I look at their history and I say, oh, they just stopped taking their steroids, all right, there's their cause. The next thing is how do I know if it's primary? With ACTH.
How do you know if it's primary? Primary, there is something with the adrenal gland itself. You're going to have a decrease in your aldosterone and renin, as well as cortisol. All of it, everything is going to be low. If you give ACTH here, you're going to have just an elevation of ACTH. The adrenal gland has atrophy or shrunk, and it's not going to be able to turn the ACTH into cortisol. So you're going to have an increase in ACTH, but a decrease in cortisol, aldosterone, and renin.
Right? Should be high in this particular scenario because again, the cortisol is low. It should tell the pituitary to make more ACTH. That's definitely possibly primary. The next thing you do is you do the ACTH dose test and the aldosterone levels. You want to know now, okay, if I give them ACTH, what would happen? Well, I already know that's high, so that's probably not going to help me. So if I give them ACTH, it's probably not going to make a difference. The cortisol will probably not change or stay low. The other thing is if I check their aldosterone levels and it's primary, that means they're not producing aldosterone, and then subsequently the renin level should go up to try to increase aldosterone. All right, that's the case. It's definitely primary AI. Then I got to think, is it autoimmune? Is it to be sure and say, oh, they just stopped taking their steroids? That's definitely possibly primary. The next thing you do is you do the ACTH dose test and the aldosterone levels. You want to know now, okay, if I give them ACTH, what would happen? Well, I already know that's high, so that's probably not going to help me. So if I give them ACTH, it's probably not going to make a difference. The cortisol will probably not change or stay low. The other thing is if I check their aldosterone levels and it's primary, that means they're not producing aldosterone, and then subsequently the renin level should go up to try to increase aldosterone. All right, that's the case. It's definitely primary AI. And then I got to think, is it autoimmune? Is it TB? Is it Waterhouse-Friderichsen syndrome? Is it some type of infiltration by tumors? So check the 21 hydroxylase antibodies, right? See if there's
what I'm learning, this is the doctor stuff. Just saying.
Component here. Get an adrenal CT MRI, see if there's any infiltration of the...
Depending on how I feel, I may or may not go back to school to get my doctorate degree. I don't think that's a bad thing at all. I don't think about that.
If there's any hemorrhage, potentially within inside of the adrenal cortex. Sometimes you can even do a fine needle aspiration to definitely determine if it is tumor or if there's tuberculosis. And you can send off your basic tuberculosis tests, such as doing the TB skin test or the interferon testing and seeing if the patient has TB. All right. Now, we move to the next step here, which is how we treat adrenal insufficiency. You basically have... Now, we move to the... Here. Get an adrenal CT MRI, see if there's any infiltration of the tumor, if there's any hemorrhage, potentially within inside of the adrenal cortex. Sometimes you can even do a fine needle aspiration to definitely determine if it is tumor or if there's tuberculosis. And you can even send off your basic tuberculosis tests, such as doing the TB skin test or the interferon testing and seeing if the patient has TB. All right. Now, we move to the next section, which is how we treat adrenal insufficiency. You basically got to replace the hormones that they're missing, right? That's the big thing. If you've destroyed the adrenal cortex, unfortunately, that damage has been done. You're not going to be able to do anything about it. You can try to prevent the recurrence by treating the underlying cause, but oftentimes it's replacing what the patient doesn't have. So in chronic adrenal insufficiency, the biggest thing is cortisol. And so in this particular scenario, you have to give them corticosteroids. So the corticosteroid choice really depends upon scenario slightly. So this is somewhat of a kind of a particular point here. So how do I know which one do I give? Well, generally the corticosteroids are kind of dependent upon the scenario. So adrenal crisis, you need IV steroids, and usually the agent of choice here is hydrocortisone. And more of a unclear diagnosis, I don't really know if the patient has adrenal insufficiency and I'm treating them as such, and I need to send off labs like the cortisol labs and ACTH labs. There is one drug that has been shown that it doesn't really alter with your the potential ACTH growth test and your cortisol levels, and that is dexamethasone. And so that would be a potential indication if you don't know the diagnosis of adrenal insufficiency, you're working them up, but you're trying to treat them in the interim. And the last one is when you know the diagnosis and you're trying to treat them more in an outpatient setting, they're not adrenal crisis, that'd be usually something like prednisone. It's going to be the most common agent. So again, replace those particular agents. If the patient does have a depletion in aldosterone, they have hyponatremia, hyperkalemia, metabolic acidosis, low orthostasis, fludrocortisone can literally replace aldosterone in that particular scenario. Adrenal crisis is a completely different story, though. In this scenario, you got to give them cortisol, but you got to give it to them, again, in the form of the most quickest way possible to assume that they get every bit of it, and that's usually in the form of hydrocortisone. The other thing is that in adrenal crisis, we're not going to give them fludrocortisone. I'm just going to do what fludrocortisone would do. And I'm going to give them sodium, I'm going to give them water. And so the other thing that I'm going to do here is in this particular scenario, because of them not having enough of the sodium and water, I'm going to give them IV fluids. The other thing is that these patients will be hypotensive, and it's because they have a deficiency in cortisol and a deficiency in aldosterone. So oftentimes it's important to put them on things like vasopressors like norepinephrine or phenylephrine to support their blood pressure. The last thing is that these patients will develop hypoglycemia. It's important to remember that this hypoglycemia should be closely monitored with continuous point-of-care glucose checks, and putting them oftentimes on an IV dextrosufusion may be necessary. Lastly, I think the biggest thing to remember for adrenal crisis, and this is something that you'll definitely get in your exams, is that when a patient has adrenal crisis, oftentimes it's that you did not give them the adequate amount of steroids that they needed to have a good response to the stressors on the body. So in other words, if a patient has adrenal insufficiency chronic, they get an infection, put them on steroids. If they're going to get a surgical procedure, put them on steroids. If they suddenly discontinue them, put them back on their steroids. So you need to give them stress dose steroids during these periods where they have an infection, an illness, a surgical procedure, so that they are able to mount an adequate response to that the body's demands have. And that is important to preventing adrenal crisis. All right, my friends, that covers adrenal insufficiency.
Okay, so we finished the lecture on Addison's disease and Addison's crisis. So with chronic adrenal insufficiency, all of it is adrenal insufficiency, okay? But if you have Addison's disease, this is chronic, okay? You're going to need to replace your cortisol, okay? Every day you're going to be taking corticosteroids. You're going to have aldosterone to be able to increase your blood pressure. So they're going to give you aldosterone, and this is really in primary because there's different ways that you can have Addison's disease. In primary, your adrenal glands ain't producing aldosterone, cortisol, or your estrogens at all. So you're going to have to get that by mouth or IV. So if you have primary, it's primary, you're gonna have to get aldosterone, okay? Replace your cortisol. That's the corticosteroid. Okay, excuse me. Yes. Now with adrenal crisis, this is where you don't have cortisol at all. Okay, your adrenal glands ain't working at all. Okay, you don't have cortisol at all to help you in your time of stress. You're gonna need cortisol. They're gonna give you corticosteroid. You're gonna have to take that. You cannot miss a dose. In all of these, you cannot miss a dose of your corticosteroid. Have a brain to let somebody know, hey, I got Addison's disease. Don't stress me out. Okay. They're gonna have to treat your hypovolemia and your hypotension. They're gonna give you IV fluids and vasopressin. Vasopressin is going to allow for you to not only hold on to your water, but it's going to constrict your vessels for you so that your blood pressure can come up, okay? Treat the hypoglycemia. They're going to give you dextrose, IV. It's going to help your sugar.
Is that when a patient has adrenal crisis, oftentimes it's that you did not give them the adequate amount of steroids that they needed to have a good response to the stressors on the body. So in other words, if a patient has adrenal insufficiency chronic, they get an infection, put them on steroids. If they're going to get a surgical procedure, put them on steroids. If they suddenly discontinue them, put them back on their steroids. So you need to give them stress dose steroids during these periods
when you have adrenal crisis to help you, because this thing is not fast. It's not going to work fast all the time. There's a time. You have to put time in the picture when you're dealing with these disorders and things like that. You're going to have, let's say you're going to surgery, you're going to need a higher dose of corticosteroid to help you through those stressful periods. If you're sick, you need to let your doctor know so they can prescribe a higher dose of steroids for you. Don't get it mixed up. When they say chronic adrenal insufficiency, that is Addison's disease, okay? And adrenal crisis is the bad, with it being out of hand, okay? So when I Google it, is adrenal insufficiency the same as Addison's disease? And they're going to say yes. Adrenal insufficiency and Addison's disease are the same condition. They just got it named different. So Addison's disease is different from Addison crisis. Addison's disease, you have enough levels to not go into Addison crisis. But it's still bad, though. You're still going to need those steroids. You're going to need steroid and aldosterone. And in adrenal crisis, where you're about to hit the flow, okay, they're going to treat your hypoglycemia. They're going to give you IV fluid. They're going to give you dextrose for the sugar. You're going to, don't miss your dose. If you need higher dosing in times of stress and surgery, you need that. And I mean that, okay? Sugar. Okay, so I'll be back on Make the Canvases for this lecture. I'll see y'all later.